Good morning, everyone. Myself, Dr. Ashwin, Associate Consultant, MRR Hospital. Today, I am going to present the definitions and the risk factor of bronchopulmonary dysplasia under my moderator, Dr. Mitali Rao. So, today's agenda: introduction, history, the first definition coined by Northway, physiological definition, 2001 definition, 2018 Jensen, and the risk factors. So, basically, BPD means the new supplemental oxygen or respiratory support at 28 days of postnatal age or 36 weeks of postmenstrual age, along with the radiological evidence of parenchymal disease. Major cause of respiratory morbidity in preterms, and the incidence is largely remain unchanged over the years, and it's also known as a neonatal chronic lung disease. So we'll see the definitions. The first, the term coined by the Northway, then Tooley in 1917 updated it. Then Shannon, Walsh coined the physiological definition of the BPD. Then in 2001, National Institute of Health updated the definition. Again in 2018, the upgradation has been made. And the latest one is the 2019 coined by the Jensen. So we'll see that one by one. So basically, in Northway, in the New England Journal of Medicine in 1967, he first defined the BPD, and there are four distinct clinical stages according to radiological and pathological basis. So progressing from the typical respiratory distress syndrome, along with the alveolar interstitial edema as well as atelectasis, massive fibrosis, consolidation of the lung with the areas of cystic emphysema and the overinflation. Then physiological definition defined by the Walsh to reduce the variability in the BPD diagnosis. So he basically focuses on oxygen saturation and need for respiratory support at 36 weeks of postmenstrual age, and assessment done at 36 weeks of postmenstrual age to check infant's ability to tolerate room air. So basically, in this, infant undergo controlled reduction in oxygen concentration, and to determine if they can maintain oxygen saturation in the room air. So generally, the fail test means the oxygen concentration falls below the threshold. Example like 80 to 87% for 45 minutes or less than 80% for the 1 minute. Then in 2001, National Institute of Child Health and Human Development define BPD as the infants who born less than 32 weeks who receive supplemental oxygen for the first 28 days, and they define BPD at 36 weeks of postmenstrual age as they categorize into mild, moderate, and severe. So in mild, there is no supplemental oxygen required. In moderate, oxygen requirement less than 30%, and in severe, oxygen requirement more than 30%, and or else CPAP or ventilator support. For those infants who born after 32 weeks, supplemental oxygen requirement for the first 28 days with severity level, they generally based on the oxygen requirement at 56 days of postnatal. Then again, 2018 they revised the definition because in the 2001 definition did not take the account of newer modalities of non-invasive ventilation, example high frequency nasal cannula, and also they did not predict the long-term respiratory outcome. So in 2018, the grade 3 has been upgraded and new criteria of radiological evidence from pulmonary parenchymal disease has been added. So preterm less than 32 weeks of gestation age, persistent parenchymal lung disease, radiographic confirmation of parenchymal lung disease, and at 36 weeks of postmenstrual age requires one of the following modalities for at least 3 consecutive days to maintain arterial oxygen saturation in the range of 90 to 95%. In this, we exclude the neonate with ventilated for primary airway disease or central respiratory control conditions. So we grades the BPD according to 1, 2, 3. So any form of invasive ventilatory support comes directly under the grade 2 if the oxygen requirement is 21%, and grade 3 if the oxygen requirement is more than 21%. In NCPAP, NIMV or nasal cannula more than 3 liter per minute, grade 1 is 21%, grade 2 is 22 to 29%, grade 3 is more than 30%. Nasal cannula flow 1 liter to 3 liter per minute. Grade 1 is 21 to 29, and grade 2 is 30%. So basically, on O2 by hood, grade 1 defined as 22 to 29% oxygen requirement, and more than 30% is grade 2. Nasal cannula flow of 1 liter per minute, grade 1 is 22 to 70%, and more than 70% is grade 2. So basically, hood and nasal cannula from flow 1 liter to 3 liter, or flow of 1 liter, generally they don't include the grade 3. They're restricted to grade 2 only. There is another term has been added, grade has been added, which is 3A, which is early death. So those neonates who born between 14 days of postnatal day, those neonates who died between the 14 days of postnatal days and 36 weeks of postmenstrual age, owing to persistent parenchymal lung disease and respiratory failure. And in this, we did not include the other neonatal morbidities like necrotizing enterocolitis, intraventricular hemorrhage, redirection care, or episodes of sepsis. Then NICD updated definition 2019, defined by the Jensen. Basically, Jensen best predicted the early childhood morbidity of the BPD and categorized the disease according to the mode of respiratory support at 36 weeks of postmenstrual age, regardless of supplemental use of oxygen. So, no BPD defined as no room air, no respiratory support. Grade 1 nasal cannula flow equal or less than 2 liter per minute. Grade 2 moderate nasal cannula more than 2 liter per minute, or NIMV or CPAP. And grade 3 includes the invasive mechanical ventilation. So basically, he did the prospective cohort study, and 18 definitions of BPD were evaluated, included 2,677 neonates born between the period 2011 and 2015, which generally 90% of those are less than 27 weeks. And mode of respiratory were most accurately predicted death or serious respiratory morbidity through 16 to 26 months of chronological age. Then Vermont Oxford Network did the retrospective cohort study on 715 centers across US, which includes 24,896 infants born between 2018 and 2022. 29 weeks of born in 2018, generally between 20 to 29 weeks of gestation. And those with severe BPD considered as required supplemental oxygen at discharge, major respiratory comorbidities, and died during birth hospitalization. So there are many historical phases of BPD. Phase 1, generally oxygen requirement less than 28 days of life, ventilator-induced lung injury. And phase 2, oxygen requirement 36 weeks of postmenstrual age, arrest of lung development. Phase 3 is the new biomarker subclinical pulmonary vascular disease or clinical pulmonary hypertension. Both the phases are pre-surfactant era and the post-surfactant era, and the major cause remains the prematurity. So while premature remains a major factor in the pathophysiology of BPD, the disease itself has progressed from one defined by the injury to one defined by the impairment of lung development, and now to one with the additional pathophysiological mechanism, including pulmonary vascular disease. So generally we differentiate into old BPD and new BPD. So old BPD generally pre-surfactant era, which is due to alternating atelectasis with hyperinflation, includes severe epithelial lesions, marked muscle hyperplasia, extensive fibroproliferation, hypertensive remodeling, pulmonary arteries, and decreased alveolarization and surface area. In the newer BPD, there is a less regional heterogeneity of lung disease, rare airway epithelial lesions, mild airway smooth muscle thickening, rare fibropolarity changes, fewer arteries but dysmorphic, and fewer larger and simplified alveoli. So this is the X-ray. We can clearly see there is a less heterogeneity in the newer one, and you could see that there is a heterogeneity as well as fibrosis in the older BPD. So risk factors. So basically, BPD is a multifactorial disease, and in which antenatal factors include fetal growth restriction is the major factor, and which is the independent risk factor, and due to impact on vascularity and increased parenchymal vulnerability. So basically, the case control study had been done, and which includes 2,255 neonates born less than 36 weeks of gestation age. And HGA had in which they found the HGA had twice the risk. Odds ratio is 2.73. Antenatal infections, unclear about its independent associations, indirectly premature births and postnatal infections, and directly inflammatory changes. Which they found the raised levels of pro-inflammatory cytokines, interleukin 6, interleukin 1 beta, and interleukin 8 in the amniotic fluid. Maternal smoking is another major contributor for the BPD. So because of that, there is arrest of alveolar growth prematurely, underdeveloped antioxidant mechanism, and risk inversely proportional to gestational age. Postnatal factors includes oxygen therapy. There has been found that there is cellular damage due to cytotoxic reactive oxygen metabolites, immature antioxidant systems. Exact duration of exposure levels are not established yet. Mechanical ventilation, newer ventilation strategy, volute trauma. Volute trauma causes more chances of BPD compared to the paratrauma. Mechanical ventilation on day of life 7 in extreme preterm increases the risk significantly. Patent ductus arteriosus, exact role unestablished. Ongoing research is going on the BPD. Early versus late versus no treatment on patent ductus arteriosus. Infection is another major cause. The postnatal bacterial and fungal infections. There is a role of ureaplasma urealyticum causes sustained immune dysregulation, and role of the azithromycin. Early exposure to broad spectrum antibiotics role, uncertain role. Epigenetics is the another newer this thing which significantly contribute to the BPD, SPB14 deletion. There is a polymorphism in genes coding for pro and anti-inflammatory cytokines. Thank you.